thanks for inviting me back. But you know, I gotta tell you, this is a little out of my comfort zone, ethics. But you know, when I thought about it, I'm thinking, is it really out of my comfort zone? Because ethics is all about doing what's right? And we really do that every day. So with that, I'm gonna start talking about some ethics, but you know, I gotta thank Colleen for giving me the last lecture of the day, the lecture that prevents you from getting out for the weekend and having a drink. So I am gonna get through this quickly, and I'll use Zach's line where, I don't know if he's in here or not, but maybe we could just scan everybody and just head out the door. But unfortunately, I'm not sure we can do that. So with that said, we'll start talking. Everybody has seen this slide probably 100 times already, so I don't think we need to go through this anymore. So the objectives. I really want to talk about what are the 4 principles of healthcare ethics. And they really fall into 4 categories when we're trying to make decisions based on ethical dilemmas we run across, whether it's in the hospital or whether it's in the home. What is an ethical dilemma? And then what are some examples? So pretty much the last half of my lecture is really going to be some thought-provoking, real live situations that we've run into within our company. And I could have went on and on with some ethical examples. So I held it down to I think 6 or 7. But there's really no right answer, but it's really just some thought-provoking. And for all of those of you that may be in home care or even in the hospital, we all run across these. And you know, we don't want to make the decisions on our own. There's really no right decision. So, you know, how do we look at it and what do we take into effect? I have no disclosures other than I'm not an expert in ethics. So when I first put this lecture together, I thought, well, maybe the first thing I should do really is take a look at the AARC Statement of Ethics. And I just went through them all. I'm not going to bore you with all of them, but I recommend every now and then pulling them out. And I think we all live by these every day. We just don't know it. It's common sense. But, you know, demonstrate behavior that reflects integrity, supports objectivity, fosters trust in our position, our profession. We want to gain the trust of our peers, of our patients, actively maintain and continually improve our competence. We want to make sure we're working under our scope of care, provide care without any discrimination, refuse to participate in illegal or unethical acts. I don't know where Joe went, but, you know, he started down that road. I had to stop him. You know, follow scientific procedures, promote healthcare delivery through improvement of the access and efficacy and cost of patient care. So again, I just wanted to go through those quickly, just touch on a few, but you know, it's not a bad idea to pull them out every now and then and take a look at them. So what are the 4 principles of healthcare ethics? And we're going to go into each one of these a little bit different. But when you pull up the 4 principles of ethics in healthcare, it comes up autonomy, justice, beneficence, and non-maleficence. I had to practice saying those words, I'm just telling you. Don't say them fast. So autonomy. So autonomy really is that our patients have the right to make their own decisions. They need to have a good, informed decision, so we have to make sure they have all of the information they need to make that decision. So informed consent. Understand all the risks and benefits of the procedure or the test or whatever, and costs, quite frankly. You know, with inflation where it's at and healthcare costs and high deductibles and all this, patients do have the right to refuse their care. And you know, we as healthcare professionals really don't want them to refuse their care, but they have the right. Autonomy, you know, is probably one of the most important pillars of healthcare ethics because the patient ultimately has the decision. Cultural or religious beliefs may come into play as well. Justice. All patients have the right to be treated fairly, and I think we all know that. Equitable treatment regardless of your religion, regardless of your beliefs, regardless of your culture. Everybody has the right to be treated fairly. Everybody has the right to all of the, you know, the distribution of healthcare aides and things like that, they all have the ability to take part in that. So they have equal access, is what I'm trying to say. I wasn't getting out there, but equal access to all of the care that they have, or they can, and appropriate treatment. And I heard Joe mention in the earlier lecture is really, sometimes is it the right treatment? When we go back to our old days of respiratory therapy and we start talking about some of the things we did, and first one that comes to my mind is incentive spirometry. We used to charge a lot of money for incentive spirometry. Come on, just take a deep breath, walk a little bit. But we got paid a lot of money. In fact, I remember years ago, and I don't know if anybody ever worked in pediatrics, we had a device that was electronic, and it had a clown face on the top. And if they met their goal, the clown's nose lit up and down. So, but we paid a lot of money for those machines, and then we billed the patient or the insurance a lot of money for those machines, when ultimately all you have to do is say, take a deep breath, or blow bubbles, or do something. Okay. The other one is non-maleficence. So really the principle is about doing no harm to our patients. It is intended for us to do no harm to our patients, but when we're talking about healthcare ethics, this can also come into play where do no harm to others around us or other patients. And when we go into some of the scenarios, you'll see what I mean by that. But you really got to think, does the benefit outweigh the risk? And whenever you're looking at beneficence and non-maleficence, you're really looking at the risk-benefit factor of the scenario. So weigh all benefits against the risks and really try to choose the best course of action. And what you'll find is there is no right answer. But you want to make sure yourself is informed, you're making the right decision, and you have help in making that decision when it comes to your patients. So perform to the best level of your competence and training. Especially when we go out into the field, we're called upon to do things that we may not be comfortable with, because when we go into the home, we now become the case manager, the social worker, the physician, whoever it may be, because we may be the last person that they've seen or the only person they see in the home, and they're asking us lots of questions. Well, we don't want to give them the answers if we're not accurate, if we don't know. We can't prescribe things for them when we get into the home. We can recommend, we can talk to physicians, but just keep in mind we want to make sure we're practicing under our scope of practice. So, whenever you talk about healthcare ethics, autonomy and beneficence really collide sometimes. And this was just a cartoon I found that, patients' right to choose, but here's a physician, what about our right to choose what you do? I go to medical school, I know what's best for you, Mr. Jones, but do you really? It's my body, it's my health. So, these come into conflict a lot. And, here's an example. 59-year-old woman who has severe COPD, had already been intubated twice. Physician explained to her that short-term intubation can help you get through this exacerbation. And patients, I don't want it. I don't want to be intubated. But we'll make you comfortable. We'll get you off as soon as we can. Well, patient doesn't change her mind. Patient's autonomy wins in this case. Even though in the physician's eyes, he believes that he can get this patient on and off the ventilator and give her an informed choice, she still decides. So the patient autonomy wins in this case. So ethical challenges in home mechanical ventilation. And when I was trying to find some articles to really support some of the things I was talking about in home care, we all know home care, it's sometimes hard to find stuff that we need. We don't have a lot of research out there. But I did run into this article by Dubuick, but it was a secondary analysis. And what it did is it looked at focus groups of individuals that include healthcare providers in the home, family members in the home, all kinds of different team members, family members of the children that come home on home mechanical ventilation, and it really looked at it from the perspective of 4 pillars of ethics. So what they found was, really dilemmas arose at all levels in the course of care for taking patients home on home mechanical ventilation. Who should receive it? Are the patients and the family members informed enough to make the decision to bring that patient home? Do they understand what is involved in the care in bringing that individual home? Is it, we have to respect the patient and the family wishes, but sometimes the patients are in a position to really not make that decision. They may not have advanced directives, so the family is making the decision for them with really not knowing how hard it is to bring these patients home and what it involves in care. Quality of life and dignity. So if you're bringing a child home, sometimes you got a little bit better quality of life because little kids are resilient and they bounce back, and we see a lot of them improve depending on their diagnosis. Bringing an adult home with mobility issues that has all kinds of problems, does the patient's family understand what is involved in that care? And I don't know about you guys, but in Pennsylvania, Pittsburgh area, we are finding it very difficult to supply nurses to our home ventilator patients at home. And a lot of this care ends up falling onto the family. So, it's really sad. We just took a ALS patient home a few weeks ago, well, actually a few months ago now. She's doing very well. But the family now has lost all their nurses. They don't have any caregivers. The agencies can't find them any caregivers to come in. So it's the family's burden now taking care of this family member. And believe me, it's taking a very large toll on this. And are some of these outcomes and some of these discussions had with patients prior to them going home? And then, we have equal access to home mechanical ventilation. So everybody should have the right to be able to go home on home mechanical ventilation if they choose to do so. So whenever I broke it down into some of the discussions and some of the things that come out of this article, under autonomy, what they found was in all of their interviews was the family really took charge. The patient didn't really have a whole lot to say. The family said, nope, we're taking mom or dad home, we'll take care of them, and it really influenced the decision of the patient. Patient doesn't want to go to a skilled nursing facility or an LTAC. They want to go home. They hear the word home, they want to go home. So the family ends up making that decision for them. They didn't believe the family was always informed of the decision. They didn't believe the family understood what was involved in caring for home mechanical ventilation patients once you get them home. And then, is the patient competent enough to make a decision as to where they want to go to be cared for? Beneficence, the decision was really based on the family's best interest. Again, what was the benefit? Is it a benefit to the patient to come home on home mechanical ventilation? I think it all depends on your diagnosis. So, if you have a diagnosis of ALS, do they understand long-term how long they could be kept in the home on home mechanical ventilation? Were they informed of the disease progress? And then the family that they, some of the families they interviewed too, the families then, once they got them home, realized what the patients, what it meant to care for these patients. They felt selfish. They felt that they were bringing patients home only because they wanted to keep mom or dad alive. They wanted them in home, so they felt selfish. And it really impacted family life, especially if there's younger children in the homes, if there's, depending on the situation in the home. But it really had an impact on their family lives, obviously, especially if you're running into not having nursing care to really help in the care of these patients. Now you're running into somebody's going to be with the patient 24 hours a day. Okay? Non-maleficence. So did the benefit outweigh the risk? Example, ALS or seriously ill end-stage children that end up on ventilators. Is it a benefit for those patients to come home? I don't want to say a burden to the family because that sounds negative because it's your family member and you want to do everything you can to make them comfortable. But, one of the things that they questioned after they got the patients home, was it a benefit, really? And then, a lot of neurologists believe it's not ethically sound with ALS to put patients on ventilators. And right now, we have 2 patients of ours on invasive ventilators at home, and they're both doing very well at home. I mean, it's ALS, so it's unfortunate, but they were informed. They had great physician care that explained to them everything, but I can tell you the physician did not want to put them on invasive ventilation. They really were trying to steer them the opposite way. But, again, patient ultimately was still in their right frame of mind, and they decided that they wanted to put her on and bring her home. So, physicians don't believe it's right to have to consider financial reasons. That was some of the things that come out of this study, was physicians believe they shouldn't have to worry about finances. Well, unfortunately today, everybody has to worry about finances. And some of these, high home mechanical ventilation patients cost a lot of money to care for in the home, especially if the insurance won't pay for private duty nursing. They're footing the bill for the private duty nursing. So it's really difficult financially for some of these patients, and I don't know if that risk or that information is a lot of times given to the patients and the family. So was the patient family educated thoroughly to make this decision? So in most of the comments that I read through some of these interviews, it really was they didn't believe the family was informed to really make the right decision. So this was another article I found where it was deciding whether you should put tracheostomy in. And it looked at patients that were on ventilators for greater than 7 days. And what they were looking at was there a good documented conversation that the physician had with the patient regarding these 4 things: their baseline condition, their functional status, long-term complications, and long-term prognosis. And what they found is 191 of the 241 patients had at least one documented conversation with a physician. 148 required further discussion before deciding. They were looking at these 4 things, and 45% of the conversations addressed none of the above. So 45% of the ones that had documented conversations didn't address the majority of what they should have in the conversation. So were those patients informed to make a good decision? So patients who chose not to have the tracheostomy compared to those who did were more likely to have a documented conversation of at least one of the above. So, it goes to show these patients need to be informed, not just a basic, we're going to make an artificial airway in your neck, it will be long-term, but really understand quality of life, prognosis, infection rates, a lot of things. So the conclusion is really inadequate information is given to patients to make these decisions. So with that baseline, thinking of the 4 pillars of healthcare ethics, I'm going to go through these case studies, and I really want everyone to think about this and how would you make the decision. And I love feedback, I'd love, what would you do? Because there's no right answer. So the first one, before we get to the first one, let's talk about what is an ethical dilemma. It's really a conflict between 2 obligations. There's no correct answer. And before acting on a decision, you really want to ask the question, is it fair? Is it right? Does it smell right? Will someone get hurt over my decision? If my actions were reported in the newspaper, would I stand by my actions? And does it smell right? Common sense will tell you if something's not right. Okay, so with that kept in mind, let's look at our first ethical dilemma. How many here work in home care? How many here have had a sentinel event because somebody caught themselves on fire? How many have had more than 1? How many have had more than 3? Okay? We could keep going, and it's not something we're proud of. And we educate patients, and we do everything we can, but they just don't listen. Okay? So the first one, case study is Mary. She was a 45-year-old lady who went into the ER with 1st and 2nd degree burns on her feet, her right index and middle finger. According to the patient, she dropped a candle on her oxygen tubing, which caught her on fire. But the physician exam in the note revealed burns on the right side of her face, which were probably about a week old. Okay? Patient had a history of COPD, obesity, hypertension. She had a lot of things going on. Patient has been using long-term oxygen therapy at 5 for the past 12 months, and her oxygen level in room air was 72%. So she definitely needs the oxygen. Okay? So patient's discharging. Physician continues. He wants her to have the 5 liters. Second fire was involved. displaced 200 people. She went to an apartment building. These are all true stories, by the way. She went to an apartment building and displaced 200 people. It was all over the news, okay? She wasn't our patient yet. Okay, case management arranged for temporary housing in a hotel, and they called us to provide oxygen because the home care company that she had would not provide oxygen. So, what do you think we should do? Patient has the right to have the oxygen, right? Is it a benefit to the oxygen, to the patient? Absolutely. Okay. So think about it. Does her physical requirement outweigh the risk? Probably, because if she doesn't have it, she's going to get readmitted to the hospital or potentially die. But is there a risk to the community in this case? Absolutely. So we're not talking about a single dwelling home. We are talking about a hotel with people in it that really have no idea what's going on. And we're putting a patient in there who caught herself on fire basically twice, burnt down an apartment building once, and our hospital system was forcing us to take this patient. So what we did is we got a risk management team involved between our hospital and our DME company. And we really didn't get anywhere. They were mad at us because we wouldn't take that patient. Because what are they going to do? Leave her in the hospital? So, who's liable in this case? If she goes home and dies, are we liable? I don't want to be on the news as Allegheny Health Network's patient, died because we took the oxygen from her. But I don't want to be on the news either because we burnt down a hotel and it killed 50 people in the hotel. So there's some really tough decisions here. And in this particular case, when our health system didn't support us and forced us to take her, now fortunately what happened, I'll tell you here in a minute, but we ended up started an ethics committee, and it all started from this very first case study because we were tired of being put in the middle of the hospital and us. So what we did is we went to our hospitals and we said, we're forming an ethics committee. We want a physician on there, we want case management on there, we want risk management on there, we want home care on there, we had somebody from our payer on there. So we have an ethics committee now that helps us make these decisions because I don't want to be the one that makes this decision, ultimately. So in this case, multiple HME providers were called with full disclosure what was happening, and they weren't able to find anybody. So the physician believed the benefit of the oxygen definitely outweighed the risk, and patient agreed to move in with a non-smoking relative and begin smoking cessation treatment. So we were able to come to a mutual decision on this patient, and actually this patient ended up doing very well, quit smoking, and is living on her own now. So it all worked out. Doesn't always happen this way, but this was a success story. So ethical dilemma number 2, unwitnessed smoking. So we heard they're smoking with their oxygen. This one's just recent for us. 65-year-old retired disabled veteran with a history of COPD, 4-pack per day smoker. Physician ordered oxygen, 6 liters. He had liquid oxygen. Complaints were received by other tenants in the building that he was smoking with oxygen. And they were very concerned because of the apartment building they lived in that it was going to go up in flames. So what do we do because this came in directly? Well, the first thing we did is we sent out one of our respiratory support specialists to do a home assessment. So they went out, completed a home assessment. Apartment smelled like smoke, smoking materials throughout the apartment. This was the best. Our risk management, and I actually heard him say this because she called him and she tied me into the phone call, spoke with the patient. He stated that he experimented 30 times while smoking with oxygen on and he never caught on fire. So there's no truth to this. And we're all laughing because I just couldn't believe it. But he was absolutely serious that he tried it 30 times. And it didn't work. So there's nothing to our, what we're saying. Because we told him if he didn't quit smoking, we're going to pick it up. Well, again, when we look at this, yes, he has the right. We have to be fair. Beneficence. Is the benefit outweighing the risk again? We're putting others at risk now. Others that have clearly come to us and complained that he is smoking with his oxygen. And, do no harm. So do no harm to not just the patient, but everyone around him. So this one, again, look at the physical requirement that the patient needs. Is there a risk to the community? Does the patient understand the risk? He didn't, clearly. He tried his own experiments. Were we liable? This is a case where we had other people in the community calling us saying, your patient, you'd bring oxygen, was smoking with oxygen, and we're concerned. Is a patient's mental status, what is it? This gentleman clearly did have some mental problems, some mental issues. And, as our ethics committee met about this individual, how can we help meet his needs? Let's take a look at his mental status, and can we help him in that respect too? So the ethics committee met, and we reached out to an outreach program that is consulted for behavioral health that he had through his insurance and through our payers. Patient agreed to the meetings, ended up, he never kept the appointments. So everybody on the ethics committee, the behavioral health team, the payer said pull it. So we ended up pulling the equipment. We had to do a police escort because he told us he had guns and he would be there waiting for us. So in this day and age, you can't, discount that. So we did. We went in with a police escort and was able to pull the oxygen. All right, ethical dilemma 3, homeless patient requiring oxygen. I live in Pittsburgh. We have a lot of homeless people. Okay, so this is Sam. He was admitted with acute respiratory failure. He's a history of a 4-pack per day smoker. Ordered oxygen 6, rest 8 with activity. We get a call he's discharging within 24 hours. Case management arranged for placement in a homeless shelter, but it's only open during 8 p.m. to 8 a.m. So what is he doing all day long? We don't have a portable concentrator to meet those needs. We can't give him liquid oxygen. Where's he going to fill his liquid from? Where does he keep all of his cylinders? Okay. So again, but justice, in all fairness, he's homeless, but he has every right to receive care and receive treatment. So we have to look at, how will the oxygen be stored? If we give him cylinders all day, what does he do with the cylinders? Is there a risk to the community? Probably, because we have no idea what kind of environment he's in. Is he smoking around in a tent we had no idea. Does the patient understand the risk? Who's liable? And again, is the HME company liable if something happens? So in this particular case, the hospital HME company refused to set up the patient due to liability. That was us. Okay. The hospital was upset with us because they had to keep the patient. Case management did find a home for him that had 24-hour placement, which is what we were asking them to do. Transport service had to get the patient to the home by 1 p.m. or the bed would be lost. He never made it there by 1 o'clock. So the transport team arrived at 1:30. The home refused the patient. Patient went back to the ER and signed himself out AMA. And he had every right to do that. So again, was it the right thing? The hospital made some errors, the transport company. There's a lot of other things out there that can help patients before saying no immediately. You really want to look at the whole picture and how can we help these patients. Ethical dilemma number 4. If you're in home care, we see this all the time. Payer requirements not met. Okay? Because we got a lot of payer requirements that we have to abide by, unfortunately. So this is Bob. He was admitted with chronic respiratory failure. He had a couple readmissions in the past 6 months. He continued to smoke. He was ordered bilevel therapy at home, actually NIV therapy. And the testing prior to discharge did not meet any insurance requirements. His CO2s were like 51, I think. But he had multiple readmissions. He really would have benefited from it. But he didn't meet any criteria. So the testing was done prior to him, didn't meet the requirements. So were any other payment options discussed with the patient? Obviously, if they don't meet payer requirements, people do have the right to be informed to make the decision, do you want the equipment? Do you want a private pay for the equipment? You just don't want to say, nope, payer requirements aren't met. Sorry, you can't get the equipment. Again, give them all the information they need to make the decision. Does the patient understand the risk of not complying with the physician's orders? Who's liable if the patient doesn't really receive care? And were all options explored by the case management team? So again, we got to look at the whole picture and really start thinking about some of these thought-provoking questions when we're making the decisions that affect the livelihood of others. So what we did is the patient was retested again prior to discharge, did not qualify. Payment options were discussed, but the patient chose not to accept anything. But the HME company, us, had an indigent program, and the patient qualified for the indigent program. So we were able to set him up, and he's doing actually very well at home. He's been home for almost a full year now. So there are a lot of things you can do for these patients. Luckily, we were able to help him. Ethical dilemma number 5, non-compliance with plan of care. The problem is once patients get to home, they're on their own. They feel like they can do anything. They don't have to listen to you. It doesn't matter what the physician says. They do their own thing as soon as you leave, right? Okay. Well, in this case, it was Joe. He was non-compliant with non-invasive therapy. He had not used it for 1 month. Physicians said, I'm not discontinuing it. His CO2s were in the 80s, and he had multiple readmissions. We, the home care company, had gone out multiple times to re-educate. We provided a few different masks, a couple different interfaces to really help this patient get on board with this treatment and therapy. And after our visits, and this went on for 3 or 4 months, no usage on the data. So, the insurance company really doesn't have any compliance data yet for non-invasive therapy, but ethically, can I continue to bill the insurance for 3 months in a row and ongoing if the patient refuses to use it and sit in the closet? Ethically, that's not right. If they're not using it, why pay us for that equipment? Yes, the patient needs it. We did everything we could to get that patient on board, and unfortunately, we're not able to do it. So we can't justify keeping it in the home. So does the patient understand the risks of not complying with their physician's orders? Who's liable if we pull it? Should the equipment be picked up against medical advice? Should the insurance company continue to pay? That takes me back to should we pick it up AMA? Well, we require patients to sign a form if we're picking up something AMA. And the physicians won't discontinue it. So we're kind of stuck in our own little ethical dilemma right there because we don't have a DC order. The physicians won't, or the patient won't sign an AMA, and it's not right to bill the insurance. So what do we do? What do you do? Pick it up? What's that? Bill the patient. Yep. Do they pay? Never. All it does is build your AR up, and then you got to write it off. So, unfortunately, those are the only tracks. I never understood why a patient wouldn't sign an against medical advice if they're not going to use it. All right. So the outcome, patient unable to use, all exhausted attempts were made. Patient did sign an AMA. He was readmitted to the hospital within 30 days. So you really have to have some strong policies in place really addressing that non-compliance with physician's orders. And especially if you do a lot of NIV in the home, you really got to make all your effort to monitor that patient, make sure they're using it, because it's an expensive piece of equipment to be sitting in a closet. So I just experienced this one, right before I had to turn my slides in. So I just got it in under the wire. Helping a coworker. So we had an employee of our company who had a very major medical horrible experience, ended up on a ventilator and I won't go through all the details, but was discharged home and within a couple days ended up into some respiratory distress, went to one of the local hospitals. They couldn't transfer her to her main hospital where she was the whole time she had this episode. So they were keeping her in the ER at this small local hospital until something opened up and they could transfer her to her hospital. She didn't like that. She didn't like that she had to sit in the ER down there, and she was signing out AMA. So she calls me on the phone and says, Kim, they'll sign a script for Duaneb, but they won't give me a script for oxygen. Can you just give me a portable oxygen concentrator to use, and I'm going to drive myself down to the hospital I need to go to. So what do you think I should have done? Good, worked with us for the last 20 years. She wants me to provide oxygen without a prescription. Can I do that? I don't care how close she is. You know, morally, ethically, number one, she shouldn't be leaving the hospital against medical advice. That's the number one advice. That's her choice. But I also have the choice to know that I'm bound by my own ethics and that I cannot provide oxygen without a prescription. And this dilemma come up a lot around COVID, whenever people were at home sick, and even at low levels, 92, 93%, they were recommending low oxygen. I can't tell you how many times people called me and said, hey, do you have a portable concentrator I can use just to get through this? No, no, no. So again, in this particular case, should I provide it? No, and I did not provide it. What are the legal ramifications? If you go to your pharmacy and you ask for extra morphine, are they going to give it to you? Now I know that's two ends of the scale, but oxygen is a drug and it is regulated, so no. And did she understand the dangers of discharging AMA? So I think that led me down the road to really give her the informed information to decide why she should not leave there. Because she really didn't get the explanation that she was in an observation bed, and they could only keep her there for so long. They were going to transfer her as soon as they had the ability to get her out. And she was in like an ICU setting, so why not stay there? She was unstable. So, I discussed that. I wouldn't dispense it. The employee did stay, and she was discharged without oxygen a week later, and she's doing really well. So, no, she probably won't. Well, she will be. She will be. But the funny thing was when she asked me that she prefaced the question by saying, Kim, I know what the answer is going to be, but I have to ask it. So she did preface it with that. So, all right. So, really when you're looking at ethical dilemmas and how you decide, you really have to develop strong risk management strategies, and you have to look at the whole picture. Form that multidisciplinary ethics team. That has really helped us in dealing with some of our hospitals, even hospitals that don't belong to our system. When we told them that our ethics committee met and we've had to make these decisions and that we cannot accept this patient, it has gone a long way other than me just making the decision not to take the patient on. So I highly encourage that, to form that committee. Really create that strong safety culture within your organization that really looks at the risks and the benefits and the safety of all parties involved. And then really, make sure your staff is educated and, their competencies are complete so that when they do get into these homes, they can help make these critical decisions. So the right way is not always the popular and easy way. Standing for right when it is unpopular is a true test of moral character. So just a quote to end you with. And I ended up early. I should get a round of applause for that, huh? You can get to your drink and you can get to your weekend faster. So, does anybody have any questions or any comments? Yes?
So back to scenario one with the lady who had the multiple fires
Mm-hmm.
in the building. What about people that may have been armed? Could she have been held personally liable if they found out the whole story?
I believe she could, and that's why I think it is so important to document. And that's what gets us through some of these sentinel events that we have to report out to Joint Commission and ACHC and any other organization out there, is if we've documented that we've educated, if we've, did everything we could, and there's no cases out there that I know of, but let a lawyer get a hold of that. So I can see down the road, because we're just seeing so much of it anymore in our area. And I can tell you, the minute I see on the news that there's an oxygen fire, I'm like typing in the address into our medical record, like, oh my God, is it our patient? And then when it's not, I'm like, whoosh, Yes, Bob.
I had a case a number of years ago in Florida that I really want to echo the importance of your point about family involvement. Had a case in Massachusetts, overweight patient, comes to our healthcare system, large patient,
Absolutely.
stroke,